Hey, good afternoon, everyone. Thank you for joining the American College for Healthcare Executives Alabama chapter webinar on hospital pricing transparency requirements. I am Dr. Chandra Bondugula, and I am the DIO for Graduate Medical Education Program at North Alabama Medical Center, and I'm the CEO of ZMed. I'm a member of the ACHE Alabama chapter board. My background is in medicine, healthcare operations, health IT, and innovation. I am your moderator today. On November 15, 2019, the Center for Medicare and Medicaid Services, CMS, finalized policies that laid the foundation for a patient-driven healthcare system by mandating hospitals to publish standard prices and shoppable services and make it transparent for patients so that they can be more informed about what they pay for hospital items and services. This will go into effect on January 1, 2021. In this webinar, you will learn about the pricing transparency requirements and how it will impact different stakeholders. You will also hear expert comments on what the future holds for price transparency and how market forces will affect the cost of care to consumers. And today's agenda, I will introduce our panelists, and each panelist will take about 10 or more to share their perspectives on price transparency. This will be followed by a moderator Q&A with panelists for about 10 minutes. We will invite all participants to pose their questions on the Q&A session. Dr. Nancy Barkowski, a distinguished professor in the Department of Health Services Administration at UAB, will compile questions and organize them for me. If there is anyone who is interested in sharing something that they have done unique, Dr. Nancy will open the mic for them to speak. And now it's my honor to introduce two distinguished panelists, Don Bulgarella and William Horton, who are well known in the healthcare industry. Don Bulgarella is the Chief Financial Officer at the UAB Health System and Senior Associate Dean for Finance and Administration in the School of Medicine. She's a senior leader in healthcare with more than 25 years of progressive experience in academic medicine. She serves as a member of the UAB Medicine Senior Leadership Team. In her uniquely integrated role, she is responsible for combined annual budgets of over $3 billion. She is a certified public accountant, formerly with Ernst & Young, and is active in the Healthcare Financial Management Association and Association of American Medical Colleges. Dawn was honored a Yellowhammer Woman of Impact in 2019 and has been named to the Birmingham Business Journal, Who is Who in Birmingham Healthcare, annually since 2015. Impressive, 4 years in a row. Congratulations. She serves on numerous healthcare boards throughout Alabama and routinely speaks on healthcare finance and leadership. Bill Horton is a partner with Jones Walker LLP and serves as co-leader of its healthcare industry team and head of its Birmingham, Alabama office. He maintains a national practice representing physicians, physician organizations, hospitals, and other healthcare providers in mergers, acquisitions, joint ventures, securities and corporate finance matters, regulatory compliance, and corporate government matters. Bill is a past chair of the American Bar Association Health Law Section and serves as an adjunct professor at the University of Alabama School of Law and as a clinical associate professor at the University of Alabama Birmingham School of Optometry. He's a national speaker in healthcare law, corporate and securities law, and professional liability. Bill will cover the legal landscape, compliance, and history of price transparency. Bill, the floor is yours now.
I thought Dawn was going to set the stage first. So Dawn, you want to, what I have to say may make more sense if you lead off.
Sure, that sounds great. Thank you, Bill, and thank you, Chandra. I appreciate the opportunity to have this conversation today. When Chandra asked me to do this, I said, well, we're 4 short months away from the actual requirement. So for many of those in the audience, I would hope that you are knee deep in actually fulfilling or trying to fulfill those requirements. But it is certainly possible that we have a number of people that are merely interested in this, don't have personal responsibility to do this in their organizations. And so what I thought would be helpful, absent very many slides, would be just to go through what are the requirements. And then, as Bill said, talk about the legal landscape, the compliance landscape around that. It's important to note that price transparency requirements are not new. Going all the way back to 2006, CMS actually began publishing information about transparent prices. And so we can debate what the definition of prices here is as we go along. In 2006, they actually identified 100 of the more common inpatient services that were provided and published the differences across the country in terms of what hospitals were submitting in terms of charges. Now, for those of us involved in hospital charges, we certainly recognize that what a hospital charges and what a hospital costs are not the same, but nonetheless, it goes all the way back near 14 years now. In 2019, we were all required to publish online in a machine-readable format a list of all of the hospital charges. It couldn't be hidden behind a variety of web screens, but had to be readily available to consumers if they wanted to access it. And I dare say for those of us in the hospital business, while we did have a few individuals to access it, it's very complicated, and unless you have a medical background, it's almost irrelevant data to the individual consumer. Most of us had some media inquiries where the media would appropriately go out and try to evaluate what the cost of something was at University Hospital, in my case, in comparison with other local, regional, or even state hospitals, so that they could accurately compare what were we charging. But again, I think as we all know, what the consumer was paying for those charges oftentimes doesn't have a real relationship to what the charges are. So the requirement that came about actually in July and firmed up in November of 2019 that goes into effect January 1 of 2021 is that in addition to the hospitals listing out all of their individual charges, we are now required two very detailed requirements associated with additional information. So Nancy, if you have those slides, perhaps we can pull those up. Great. There we go. And ideally, we'll be able to share these with you all if anyone is interested after the fact. So there's two specific types of required disclosure, again, starting January 1st of 2021. The first requirement, as we've attempted to detail out on this slide, is that in addition to the charge, the description, that each hospital would list out what its standard charge is, would then list out very specifically what each of the payers that you have negotiated a rate with will pay for those charges, what you as a hospital would charge to an uninsured patient if it's in fact something less than the charge that's listed on your charge master. And then you would have to identify what the overall minimum rate that you accept for that charge is, and what the overall maximum rate is that you would accept for that charge. Go ahead, Nancy. In addition to that very, very explicit information, which for a place like University Hospital, we're still trying to come to terms with how large is that Excel file going to be. I say Excel file because it is machine readable, and so there are certain characteristics that you have to have to it. You can't just have a PDF file or something along those lines. Excel files obviously will be very easy to print off, easy for individuals to go through and try to identify specific trends in those charges, easy to compare that Excel file to another to determine what is University Hospital charging versus other players in the market or even in the country. The second requirement, in addition to all of your charges, is a listing of 300 what the government has deemed shoppable services that the average consumer would be looking for to compare one hospital to another. CMS has given us 70 specific services that have to be listed in those 300 services if in fact your hospital provides those services. And then each hospital gets to determine what the other 230 are to fill out its list of 300 services overall. They've stated in picking your 230 shoppable services that it needs to be something that a consumer could call to schedule. So obviously radiology services are going to come into play there. amongst others. The published rates that we're going to list on those 300 shoppable services are going to be the same as those that are listed in the all-consuming list that we have there as well. And in this particular case, they've given hospitals an option that instead of just creating this Excel file or something like Excel, you can actually use a price estimator tool. So in most cases, that's a tool that the hospital would go out and purchase from a third-party vendor. So let me give you a couple of examples of that. Next slide. And I think we're going to click through this one. So as an example of a price estimator tool, again, that would be found on the hospital's website, I would come onto that website and I would select that I want to start an estimate for a service. It's very important to know that in the CMS requirements, I don't have to identify myself in this price estimator tool such that that the hospital could come back and contact me on that. We will have a number of disclaimers on the price estimator tools to state that this is not a negotiated rate. It is merely an estimate of what I, as the consumer, think I would like to see. So the next component of this. So I've said, yes, I want to have an estimate of something. And then it comes in and says, well, what location do you want to utilize? What type of visit? Is this an inpatient visit that you're wanting an estimate on, or an outpatient visit? And then very specifically, what is the procedure or service that you're asking to get an estimate on? So the next slide. It has the option to come in and ask me, do you have insurance or not? Now that's an allowable question on the price estimator tools. If you don't have insurance, then you're going to be given an uninsured rate. If you do have insurance, dependent on the price estimator tool that you choose, the tool can actually bounce back against my insurance plan to help me determine what my out-of-pocket costs are going to be on the service that I'm choosing. Have I met my deductible for the year? Do I have a co-insurance or not? And so in this particular example, you can see that it comes in and it gives me a price. It merely tells me that this is an estimate. It tells me what my copay portion is, my deductible, my co-insurance, and so on. It does, in fact, detail, and it is required to detail what the insurance plan will pay to the facility, as well as what the charge that the facility has out there is. I think that the price estimator tool, if you can get down to this level of granularity, is actually what the consumer is looking for when they want to know what is the hospital charging. It's more about what am I going to have to pay of what the hospital is charging. And then the last slide. If you choose not to use an online price estimator tool, again, it can be something that you've developed, but more often than not, it's a third-party vendor selected option. If you choose not to do that, CMS has gotten very specific in terms of what you would have to disclose as a hospital on those shoppable services. You have to detail out what the procedure is, in this case, colonoscopy. You have to detail it out in a way that the patient can understand it. You have to state all of the services that the patient would encounter or potentially encounter in receiving that service, and whether or not they're going to get a bill from you, the hospital, or a bill from an outside entity. If it's a bill from an outside entity, you can see that CMS has stated that you don't have to disclose what the price would be, only that you would have a separate billable service. And that's the end of the slides. With that, what I thought we would talk about before I turn it over to Bill is simply what the complexities are from a hospital setting in complying with all of those requirements. What is it that we think is going to come from complying with all of those requirements? Well, as I've referenced, I don't think that most patients are very interested in what the charge is from the hospital. They may or may not be interested in what all of the insurance plans are paying. They're certainly going to be confused about why is my insurance paying X amount and another insurance is paying Y amount. Because we are in fact having to show what we would charge to an uninsured patient, if it's something less than the total charges all in, I would expect that we're going to have some patients with high deductible plans that may be more interested in paying out of pocket than utilizing their insurance at all. I would imagine that all of the hospitals, perhaps even the non-hospitals, but those involved in healthcare, and certainly the insurance plans, on day one are going to go out and query what are all of the charges and what are all of the reimbursements rates. I'm going to want to know, am I being reimbursed the best in the community? And if not, then going back to that particular payer for sure to say, hey, I thought I had the best rate. Why don't I have the best rate? In an academic medical center, we're overly concerned about the price. Things are more expensive routinely in an academic medical center because of the types of services that we're providing, whether that's residency services, trauma services, clinical trials, and the like. And none of this information is going to be case mix index adjusted. So it's going to be very easy for a consumer, or certainly from a media perspective, to pick apart academic medical centers in comparison to their community counterparts, and why are things costing more, why are insurance companies paying more in those locations. With that, I'll leave it up to Bill and all the legislative and legal issues around this.
Thank you, Don.
Thanks, Don. And the legal landscape here, I think, requires a little bit of historical background, because this is, I suspect everyone on this call or in this Zoom meeting would agree, this is a weird industry. It is not an industry that runs like others do. It's not an industry that has, sort of intuitive and transparent economics associated with it. I mean, Dawn just mentioned one of the key factors. If your situation is such that you're getting care at an academic medical center, then the cost of that care is going to be higher, because an academic medical center has greater resources that it has to support and is compensated in a different way at a different level. So those charges are always going to be higher. What your insurance company, if you have insurance charge, is always going to be higher. But that's not something that's easily understood by consumers. And you go back, and I think you sort of can trace some of the momentum behind transparency to some lawsuits that were brought now approaching 20 years ago on behalf of uninsured patients. And there were a number of class action lawsuits brought around the country saying, well, gee, there are uninsured patients who are being charged master charges, and they're the only ones that are paying charge master charges. The insurance companies, the insured patients, are being charged much less. And so basically this is a way to gouge indigent and uninsured people. And that got, I think, probably a lot of attention for the first time to the general public, is this whole issue of price transparency for healthcare services, and particularly hospital services. And so over the ensuing years, you saw more and more concern about price transparency addressed. You saw more and more legislative activity, particularly at the state level, requiring disclosures of hospital pricing. But typically those disclosures were the disclosure of charge master charges. And as everyone knows, charge master charges don't bear a lot of relationship to what people generally pay for healthcare. They don't bear a lot of relationship to what it costs a hospital to provide care or costs a physician to provide care. They're kind of, they're numbers that are sort of easy to look at, but they're not easy to understand. When the Affordable Care Act was passed in 2010, it included the statutory provision that essentially authorizes and requires the regulation that we're now looking at going into effect in January, because the Affordable Care Act is big on data. There's kind of a central thesis running behind the Affordable Care Act that says essentially people will be better consumers of healthcare the more information they have, and providers of healthcare will be better incentivized to provide quality, cost-effective care the more information is available to the public. And you can debate that. There is, ever since we all began living on the internet, there is this sort of conception that, well, an intelligent consumer ought to be able to go and find out, whether a book he or she wants is cheaper on Amazon or on Books A Million or on some other website. If I want to fly from here to San Diego, back in the days when you could actually like get on airplanes and fly from here to San Diego, I could go and look at various airlines and see sort of what the prices were. And if I were indifferent to things like loyalty programs, I could pick the one that was cheapest or the one that otherwise served my purposes best. And so there's this thought that, well, why can't we do that in healthcare? And of course, part of the challenge there is prices are not meaningful all that much in the provision of healthcare services because, every insurer pays something different. Medicare pays something different. Medicaid pays something different. And for most things, providers are not really price setters. They're price takers. Medicare does not typically come to a hospital and say, okay, how much will you sell us an appendectomy for? Medicare says, here's what we're going to pay you for an appendectomy. And if you participate in Medicare, this is what you have to sell it to any Medicare patient who comes to your door for. So this is all kind of illusory, but the Affordable Care Act, as I said, sort of believes in data. And so there's a requirement put in that hospitals disclose, what their prices were for services provided. And that was understood, I think, by most people to mean kind of what we had sort of gotten used to, that hospitals were going to be required to disclose charge master prices. And you were going to get this list and it was going to be put in a consumer-friendly format. And it wasn't actually going to tell you that much of anything because charge master prices don't tell you that much of anything. And it would be kind of a pain in the neck, but it would be there. Consumers could access it for whatever it was worth. You were required to put it up in a consumer-friendly format. And it was kind of going to accomplish whatever it accomplished. Then we had a proposed regulation put out and notice and comment period, and then a final regulation put out, which is what is scheduled to go into effect in January. And that, sort of yielded an unexpected result because while everybody was sort of resigning themselves to, okay, we're going to have to take this data, this information, and format it in the way CMS wants to see it, and we're going to have to put it on our website, and we're going to have to, be under some fairly tight constraints on where it has to show up and how it can be accessed. But I don't think anybody expected what came out of the final rule, which is what Dawn has just told you, is that you end up having to prepare these enormous lists that show if you've got, contracts with 20 different payers, you got to put your quote unquote, negotiated rate for each of those payers up there. If you've have cash discount prices, you've got to put them up there. You've got to put up this minimum and maximum negotiated rate, which is kind of, I would argue, not a terribly useful piece of information, but it's there. It requires a lot of information that, I think arguably is going to be of limited utility. The argument, of course, and there is merit to this, is as more and more people have high deductible plans, more and more people have medical savings accounts, more and more people are, seeing benefit reductions, even if they've got an employer-based plan, benefit reductions, and narrower networks. There's an argument that, well, it makes some sense for people to be able to go and actually shop their out-of-pocket cost in an intelligent way. I'm not sure this is going to do that because, again, the information, even presented in user-friendly format, a lot of this information, I would say, really doesn't tell you a whole lot that's meaningful. The most meaningful thing for insured patients is the sort of tool that was on the third slide that Dawn put up, where you actually plug in sort of real policy information and it can give you a real estimate. But nonetheless, this is what the rule says. So, as you might expect, no one in the hospital industry was particularly happy about this. So the American Hospital Association, joined by some individual hospitals and health systems, and ultimately by other hospital associations, filed suit against CMS, attempting to keep this regulation from going into effect. And a couple months ago now, the U.S. District Court for the District of Columbia ruled against the AHA on that and basically says, no, you got to comply with this rule. The rule's fine, it's going into effect, and you better get ready. AHA has appealed that. It is on appeal to the DC Circuit Court of Appeals, and conceivably, depending on how that goes, could go from there to the US Supreme Court. Unless the Court of Appeals decides to essentially put a stay on the district court's order, meaning keeping it from being enforced until there's a resolution by the higher court, that's not going to be resolved by January 1st. One hopes that the court may put a stay in place because this is going to require a whole lot of effort, and there are some hospitals that have been planning for this. There are others, I'm sure, that have been waiting to see, whether it goes away, but the time for doing that has passed. But realistically, unless the DC Circuit grants a stay, this is going to be, what has to be up and going on January 1st. And it's a challenge. Personally, I think the AHA has very good legal arguments. I think that the regulation, frankly, greatly overextends what the statutory language allows it to require, but the AHA has very expensive lawyers. They argued that in the DC District Court, and they got totally beat down. So while I think they've got a good case, that doesn't tell you anything about how it's going to come out. So now the focus of this is, okay, what do we have to do to comply with this? What do we need to be thinking about? How can we address this? And what I suspect is difficult for some of you, it's difficult for me, and I'm not even in that end of the business, is to get past the frustration that a lot of these requirements are really sort of counterproductive or at least not helpful, and just bite the bullet and go ahead and do what has to be done. Taking comfort in the fact that CMS says when you put out rules, you're required to put an estimate of the cost to comply with the rules. And CMS says, I think it's going to cost around about $12,000 for a hospital to comply with this rule. And, I'm sure no one on this call or meeting would disagree with that. I mean, most people feel like CMS, left some zeros off of that, but that's what they say. But anyway, that's the landscape we're in right now. And while I think there are lots of bases on which the regulation is poorly drafted, overreaching, and vulnerable to attack, so far, the only court to consider it has not found that to be the case. Whether the DC Circuit will, and whether when the DC Circuit rules, it will get appealed by one side or the other up to the Supreme Court or not, is anybody's guess. So that was a lot of talk without a whole lot of useful information, I'm afraid, but that's kind of where we are right now. And so I think now our time is to start talking about, okay, well, what do we do? How do we respond to this?
Bill and Don, thank you so much for the insights. Actually, it's very helpful. And as Nancy is organizing the questions from the audience, let me ask a few questions to our esteemed panelists. So, Don, you're a leader of the big system, and you have UAB is well positioned for this requirement. So how do you see the smaller hospitals taking this responsibility and challenge? So what kind of resources they need? And I know you're helping a lot of rural hospitals to comply with this. Thanks for that leadership. So how do we help all Alabama hospitals to take care of this problem, the situation right now?
Sure. So I think the hospitals have the challenge of, do they have the expertise in-house not only to pull the information, because I think that most in the financial space could pull the information, what are my charges? The number of man hours that it will take to go in and decipher the contracts that you have and put those alongside of your charges. So Medicare and Medicaid are off the table, but even if you have 20 managed care contracts, they're not as straightforward as X percentage of charges. I mean, they have all sorts of nuances in them. So do you have the expertise and the man hours in-house that you can pull that information together? Would be step one. And then if you do you have the website and the IT ability, if you will, to maintain that on your website? I mean, we, as large as we are, you can imagine the largesse of our charge master and then all of the managed care contracting information that's there. So while we certainly have individuals that will put that appropriately on the website and make it in a user-friendly or as user-friendly as you can, what happens if 10 people at one time go on and try to download or query information in there? So is your system going to be capable of maintaining itself, if you will, when you have all these individuals that are doing that? And then the last piece of it would be the communication. How do you communicate with your leadership of your hospital, your board members, your patients, your physicians, and that sort of thing? What's going to be out there? And then the nuances that come with that. So I can tell you that there are a great number of third-party consulting companies, third-party vendors that very quickly recognize what this requirement was, and they're selling those services. And so that might be a viable option for you. I don't think Bill referenced it. It wouldn't surprise me if there are some hospitals that say don't have the manpower, not going to do it. And if you are discovered in a CMS audit that you haven't done it, the fine is $300 a day. And so is it worth $300 a day until you could get something up? Probably more than anything, not only the $300 a day, but then you're listed on the CMS website as non-compliant. I don't think anybody wants that designation. So if you're just now getting started, maybe you've waited long enough, like Bill referenced, that we thought that this was going to get overturned, particularly with the pandemic. We thought this would get delayed. It doesn't appear that it's headed in that fashion. You may not have enough time on your own at this point, so you may need to reach out to someone, to a consultant firm or something along those lines.
And the one thing I would add to that, and Don, thank you for reminding us about the fines, because I meant to mention that and forgot to. One thing that is, potentially good, but potentially bad, what we've seen throughout this pandemic period, I would suggest, is CMS acting in a rather reactive decision-making environment. What CMS has been doing, what HHS has been doing, has been putting stuff out there, realizing that what they put out there may not be viable or feasible under current circumstances, and then kind of at the last minute changing it. So while I wouldn't give up hope, particularly if we don't start seeing more abatement than we've seen in the pandemic, I wouldn't give up hope that there may be some relief. I certainly wouldn't count on that. I think at this point, we've got to assume that, as frankly as has happened with some other things, if CMS backs away from this deadline, it's probably going to do it at a point where most people will have already undertaken the process anyway, because you can't afford to wait. It's frustrating, but I think that's where we are. And I think we've got to assume at this stage that unless the court intervenes and stays it, that this rule is going to, is in effect and is going to require this to be done by January 1st.
Thanks, Don and Bill. And we have one question from the audience. So, given the complexities around hospital billing and charges, facility, professional, etc., do you think this legislation will help consumers or just cause more confusion? I know, Don, you have touched on this one, but
You know, I think that the price estimator tool is probably the most useful of all of this information that's there. So, you know, Bill made reference to if we want to fly from here to San Diego, we can go online and select that what airline, what time of day, how many stops I want to have, because, you know, all prices are not the same, right? And so they're valuing your time and your convenience and that sort of thing. When we compare that, and it's a routine comparison to looking at hospital charges, there are very, very few things that individuals are saying, hey, I'm going into to the hospital. So this is not a doctor's office, but I'm going into the hospital for X. And even if I knew, if I was medical enough, or for me at least, if it was simplistic enough that I say, okay, I know I'm going in to the hospital for X, am I willing to shop for that service? Or more often than not, I've already selected the location because that's where my doctor has told me to go. That's where my doctor is practicing, or I have some knowledge, perceived or real, about the quality of the service in that location. So do I think individuals are going to use it for the data, to Bill's point, that it was intended? Likely not. I think that the more accustomed, so there's not a delay and people do start using it, maybe consumers will come to the hospital or to the physician office a little bit more knowledgeable about their out-of-pocket responsibility. Maybe I've gone online and I know I'm going in for an MRI. I don't know what my copay for an MRI is at that location, so I might search that. But you have to admit, if you are going into the hospital for something significant, or cancer treatment or heart treatment or so on, of all of the concerns that you have, chances are my out-of-pocket cost is in there in my list of concerns, but I'm not going to change where I'm seeking that service as a function of that. Will it do what the government has intended, which is to make more competition, if you will, amongst price setting and so on? Perhaps. But then again, you've got to have a case mix index adjustment added to it, a quality index added to it. Am I willing to pay more for something simply because it's in the location that I want? Or am I willing to pay more for something because I understand the quality of the service that I'm seeking, or it's the only provider in the area that provides that service? And so I think you'll get some downstream from it, but not as much as the effort to put this in place is, in my opinion, right now.
Yeah, I would argue, I mean, that the competitive impact is overstated, because honestly, if you put all the information that's required out there, as you're required to do, that would tend, you know, assuming basic economics works, to bring a convergence of what payers are willing to pay for a service, what providers are willing to sell it for, and actually you would end up with a much narrower price range than you have now. So that'll be good for some people, bad for some people, but it's almost more information than you want out there if your goal is to, you know, foster competition. Where I think, if I were a hospital and I could do it, what I would focus on is this, on the shoppable services disclosure. I would focus on whether I could put up a price estimator tool of the type that we've been talking about, where a patient can specifically put in information about their plan, what they need, and get, you know, some level of reliable answer as to what their out-of-pocket is going to be, because that's what people want to know. And I think a hospital that can do that can satisfy the requirement that way, you know, at some level, that's positive, you know, positive marketing for the hospital, because people are confused by this. The more the hospital can make it easier, the more likely the hospital is going to get sort of a halo effect of being consumer friendly. So I would certainly do that if I had the ability to do it. But you know, unfortunately, the problem is, again, this requires the disclosure of a lot of information that I would argue is not useful and also doesn't take into account, I think what Don said is right. If I need a particular hospital service, the vast majority of the time, I'm not going to shop around. I'm going to ask my doctor, where can I get this? Or where are you on staff? Or where is the surgeon you're referring me to on staff? If I am in Demopolis, where I grew up, then I'm not asking any of that because there's one hospital in town. And the choice is, do I stay there if the service is offered there, or do I go to Tuscaloosa or Meridian or something? It's not that pricing has no influence on people's decisions, and it certainly has more as people have gotten more focused on out-of-pocket costs and out-of-network charges and that sort of thing. But it's just not the fundamental way most consumers shop for hospital services. And so I think, again, the thing that annoys me about this is you're looking at a fairly significant cost to the system in putting this up. I don't think that cost is going to be repaid in actual consumer benefits.
Yeah, we're saying the same thing. I agree.
So another question, what will large self-insured employer groups do with this information? So Don, you have touched on high deductible, and both of you have touched on high deductible health plans, but how would the large employers, self-insured employers, can help take this information to help their employees?
Yeah, I think, and I'll just, for variety, I'll jump in first and give Don some targets to hit. One, I think that's going to depend on the nature of the employer. Well, it's going to depend on several things. One, are we talking about, a national self-insured employer, a Walmart? Or are we talking about a large local employer, an industrial company or something with 500 employees? Because they're going to have different needs. What kind of self-insurance plan are we talking about? Are we talking about something where the employer is going to go out and actually bargain with providers, as some large employers have done? Or are we talking about the situation where the self-insurance plan is essentially sort of a corporate level high deductible plan, and the corporation is going to contract with Blue Cross or a large payer to act as the TPA for that plan and essentially give that plan, the benefit of its contracted rates? I think it is going to be useful to the extent it's going to be useful. I think it is going to be useful to large self-insured employers because they are going to be more price sensitive because they're paying these costs out over a large pool of people, and they, at least hypothetically, have the ability to have internal folks or hire consultants who can interpret it for them. So I think it's marginally more useful in that setting, but I think it depends a lot on what kind of employer you're talking about and sort of how active that employer is in doing hands-on contracting with providers, as opposed to essentially just, having a large self-insured retention, but then buying into a regular third-party payers network.
I think Bill's right. The answer is going to be, it depends. You've got large national employer groups that are self-insured that are already doing those sorts of things with big ticket items, where they do contract with national health insurance providers outside of their area for things like transplant or cancer treatment or things of that sort. You may see some increased use of that. By and large, it will depend on the employer. I would agree with Bill.
Mm-hmm.
I agree. Thank you. So one more question. Is there any legal issue with allowing an insured patient to be treated as self-pay if they choose to be based on high deductibles?
I think actually I could simply record a tape saying it depends, and that would be my contribution to the rest of the discussion. It depends on the provider contract. Let's take the easy one. If I'm a Medicare provider and I have a Medicare patient coming to me for a Medicare covered service, I cannot charge that patient anything different than what the Medicare out of pocket is, I can't say, I will give you something extra if you will, pay me more than the Medicare deductible, or I will, you can't do that. And ultimately, if you do that, you do things that could cause you to have to pay a lot of money to the government or go to jail. If you're talking about a private insurance plan, typically the provider contracts are going to say you have to, our insureds, you have to honor our contracts with our insureds. And if you don't do that, you run the risk of losing your status as a provider. You run the risk of having them cancel or not renew the contract. In the situation, and let me put it in an analogy that's sort of down home, I've got a car insurance policy with $1,000 deductible. If I have a fender bender where the damage is less than $1,000, I may well say to the other person, look, why don't I just pay you the $750 it's going to cost to get your bumper fixed? And that way I don't have to file a claim with my insurance company. It doesn't, go against my premium. By analogy, if you had a patient who came to you and said, gee, I've got this big out of pocket, how about if I just pay you XYZ, would you sell me the service on a cash pay basis? Technically, if you're in network with that patient's payer, you violated the provider agreement and you could be subject to termination as a provider. Realistically, I'm not sure how easy it's going to be to find that out. But I don't think it's a risk-free proposition. I don't know that I think it's necessarily all that risky a proposition for non-governmental payers, but it's certainly something I think you would want to look at, your provider arrangements, and you would also want to, I would suggest, make a very individualized determination in that case as to why we are doing this for this particular patient, much the same way that you make an individualized determination of whether somebody fits within your financial assistance policy or not. I think it's a lot easier to defend something where you can say, this is the specific reason we did this for this patient in this case, than it is to say, oh, we'll do this for anybody who walks through the door.
And Chandra, what we will have is patients, if you have a rate that you charge uninsured patients, we definitely will have patients that will look at the balance that's left after their insurance company has paid, whether they have a high deductible plan or not, and then compare that to what you would have accepted for an uninsured patient, and then challenge you on whether they're going to pay their bill or not. Now, Bill's right. We are required to bill you to the fullest extent that we can, where you have a portion of that, but that's not going to refute, every phone call that we get in related to that. So that will be one of the downsides from that information if you do have an uninsured rate.
Mm-hmm.
Thank you, very informative. So there's one more question. Will this get linked at some point to the surprise billing efforts?
Linked, it depends on how you mean linked, but I do think this is all part of a continuum. Mm-hmm. In Alabama, we are somewhat insulated from it because of we have a dominant player in the market here that particularly in the employer sponsored insurance arena has, a whole lot of the covered lives and virtually all the providers in the state under contract. So we don't see this as much as they do in states that have, a more fractionated payer market. But you are seeing, you see, the complaints of people who say, well, I went to this hospital because it was in network, but I went to the emergency room and the ER docs weren't in network, and so I got a bill for $5,000 for having somebody look at my sprained ankle, and I don't understand this. So I think sort of psychologically, you are going to see some linkage to that, and I think one of the challenges with this disclosure is, even though you were supposed to put up in the consumer-facing disclosure an indication of what isn't paid for as part of your hospital bill for a particular condition, that's going to be hard for people to understand. And I do think you're going to see that resentment that, well, I looked on your website and it said I could have this procedure done for this. And then all of a sudden I got slammed with this anesthesia bill and this, this surgeon's bill and other things that, weren't in that number. And I never would have come here if I'd known that was going to happen. So, I mean, I think they're very different legal issues, but I think psychologically, when people look at it and say, okay, what are we mad about? Those things are going to get melded together.
Mm-hmm. It's not unlike now having to pay for luggage on an airplane, or if you wanted a snack while you're in there, or access to get to my seat earlier, so on.
So we have we will entertain one last question. So before that last question, let me share with you about something forthcoming opportunity put together by Alabama Healthcare Executives Forum. On September 18th, from noon to 1 p.m. Central Time, the Alabama Healthcare Executives Forum presents a virtual free webinar on acing a virtual interview, new opportunities in the new norm. So again, for this question, so Bill, you have touched on the legal landscape. So one of the very many people have shown interest on this one. What would be after the elections? How would you think this price transparency would shape out?
I think it's really a question for Dawn. This is a very interesting question, I think, because in some ways, in this area, I think this election is kind of flipped on its head, because here you have what I would argue is a very onerous regulation, put in place by a Republican administration, and a Republican administration that otherwise likes to talk about all the regulations it's getting rid of. And so it sounds weird to say, okay, well, if the Democrats win, is that going to cause this to be revisited? I think it might, just because there are so many, bluntly, because in my mind, there's so many things wrong with this regulation as it currently exists. I think it needs to go back to the drawing board. CMS has to do something because it's in the Affordable Care Act. It's a statutory requirement that they do something. I don't think that's the right thing to do. And I would like to think that, a new administration, if one comes in, would be a chance to review that and revisit that. And certainly I think there will be, lobbyists who will be endeavoring to do that. That having been said, whoever wins the election, there are going to be a lot of issues to face. And this is not one that, really resonates. It's kind of a technical issue. And even though the subject matter resonates with the population, the kind of stuff we've talked about on this call, the technical challenges and the utility information it's kind of wonky stuff. So I don't know that anybody is going to say, on my first day in office after inauguration, I'm going to issue an executive order, wiping out this regulation. It's just not it's not a terribly sexy thing to lead off with.
Thank you.
And I hope that somebody does say, well, this is my first day in office.
In the words of the original British House of Cards, you might very well think that. I couldn't possibly comment.
Thank you. So I hope this webinar was as informative as it was to me. My own learning from this webinar is to be prepared for this huge disruption coming our way. On behalf of the ACH Alabama chapter, we thank the panelists for their insights. Thank you, Dawn and Bill, for your leadership and what you do for the healthcare community. And it has been great pleasure for me to interact with you in the last 2 weeks to discuss about this topic. And thank you for giving that time.
Thank you so much for having us.
Sure. Thank you, participant. Thanks for your time and questions. Thank you, SCHA Alabama team, for making this happen. We will see you on September 18th. Have a great week.
Thank you, John.
You too.